Hello, welcome to our live webcast, The Throwing Athlete. Thank you for joining us. My name is Caitlin, and I will be the operator for tonight's presentation. Before we get started, I would like to take a moment to acquaint you with a few features of our web event technology. On the right-hand side of your screen, you will see our text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, hit in the text box and type your text. When you're finished, hit the send button. All the questions that you submit are only seen by our presenter today, and your questions will be responded to in the order in which they were received, and they will be addressed at the end of our presentation. At the conclusion of today's program, we ask that you please complete a brief post-event evaluation. Please take a moment to complete the survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Samara Friedman, board-certified pediatric orthopedist who practices at the Pediatric Orthopedic Center in Cedar Knolls and Springfield, New Jersey. And now, with that, I would like to turn the microphone over to your speaker, Dr. Friedman, for opening remarks.
Hi, welcome. Thanks for joining in tonight. My name is Samara Friedman, and I'm a pediatric orthopedic surgeon with the Pediatric Orthopedic Center. And I'm going to be discussing injuries in the throwing athlete tonight. This is a topic that I really enjoy, near and dear to my heart. A few things you should know about me. I coached my son's Little League team for 3 years until he broke my heart and quit baseball and switched over to tennis. Been coaching my daughter's Little League baseball team for 6 years, and she just graduated out of Little League and is hoping to go on to high school baseball when she graduates middle school in a year. And I am a very big Yankees fan. I will also root for the Mets, unless they're playing the Yankees, but I will always root against Houston Astros and the Boston Red Sox. So now that we've gotten that out of the way, so who are our throwing athletes? It's not always as straightforward as you would think. Basically, they're the athletes with a very unique and specific pathology related to the tremendous forces generated during the throwing motion. So there are some athletes that throw a ball as part of their sport, but don't really qualify under that definition as a throwing athlete, and then other athletes that don't throw a ball during their sport, but actually do have some of the pathologies you see in the throwing athlete because it's a similar motion. So it really includes your football quarterbacks, your javelin throwers, not so much your discus and shot put. It's a very different throwing motion. But it can include someone serving a volleyball. It can include tennis, also particularly during the serve is very similar to a throwing motion, so is slamming the ball. Basketball, one of those sports, very ball heavy, but not really your quote unquote throwing athlete, and that's really not the type of injury pattern we see in basketball players. To an extent, your bowlers, your softball pitchers, they have similar movements and will have a similar constellation of injury patterns. And then your overhead throwers during softball and baseball, and then as I mentioned before, your javelin throwers. Those are sort of your prototypical throwing athletes. But nothing really creates as much force and as much stress as your baseball pitcher. So that's what I'm going to be focusing on this evening. So these are some of the type of injuries that I'll be discussing. They are sort of the most common that I see in the pediatric population, which is generally about 21 years old and under. They include muscle strains, tendon strains, tendinitis, apophysitis, epiphysiolysis, osteochondritis dissecans lesions, Panner's disease, labral tear, impingement, shoulder instability, and chronic or acute on chronic UCL sprain. I'm going to be skipping things that you're going to see more in your adults or that are more obscure, like rotator cuff tears, extremely rare in my population, at least to the point that they're symptomatic. Sick scapular syndrome is sometimes seen in throwers, but again, more in adults, and relatively obscure, so I'm not going to really be touching on those things tonight. But all the things listed here have one thing in common, and that is they are all have a component of overuse as the primary mechanism of injury. So overuse injuries are typically from repetitive type of tasks. There's tissue damage resulting over time from repeating the same motion again and again and again. And that microtrauma to the soft tissues eventually exceeds the body's rate of repair. So it's almost a race between your body trying to repair the micro damage from these movements or motions and it overwhelming the body's ability to repair it. So if you overdo it at the gym, for example, you're going to feel that next day, and that's that micro trauma that's occurring. But if you rest it, foam roll it, take care of it, and then go back to the gym after 48 hours, maybe start a little lighter, you're going to allow your body to repair from that micro trauma, and the soreness will get less and less each time you go back to the gym. When the soreness becomes more and more frequent or more severe, that's sort of your earlier signs of an overuse injury. Typically, the injury is chronic in nature. It's a gradual increase in the symptomatology, but it can also be acute on chronic in that the person is having pain, and that pain is at a relatively low level that they're capable of functioning through, but then ends up with an acute increase in severity, and that's where you get your acute on chronic injuries. So in the soft tissues, that's going to result in muscle strains, tendon strains, tendinitis, fraying of the labrum of the shoulder, the chronic ligament sprains. In the bone, the overuse injuries are going to result in damage to the physis, the growth plate, stress fractures, and OCD lesions. And you start off with general tissue inflammation that generally progresses with more and more microscopic damage, and then, like I said, sometimes acute on chronic worsening. And these symptoms will occur generally in a predictable progression. Not always, but oftentimes. So first they'll start having pain after the activity. They'll be able to throw a complete game, and then they'll be a little sore in their shoulder or their elbow afterwards. And then if that is permitted to progress, then they'll start having pain while they're throwing the ball, but they're still able to get through their games. And then it'll progress to the point where they start having pain while they're throwing. And now you're talking about a more advanced overuse injury at that point in time. And then finally, they'll have pain even at rest. So they'll have thrown one day, they rest it, the next day they're still having pain with just activities of daily living. And so they're having sort of pain at a low level at baseline, and that will continue from one start pitching to the next. So there are a lot of different factors that contribute to these overuse injuries, particularly related to the growing population, the children. So with rapid growth comes changes in the body that might throw off their mechanics. They might be used to having a smaller, compact frame, and then they start to grow, and it might throw off their pitching mechanics if they're not actively working on it. In addition, as they grow, they get stronger, so their velocity is going to increase over time, which also puts more strain on the shoulder and on the elbow, which is where most of your pathology is in the pitcher. So now you're looking at someone who maybe has poor mechanics and throwing at a faster velocity, and that's going to contribute to an injury from throwing, from overuse. Lack of flexibility or stretch, or lack of sufficient stretching will play into this. If the muscles are tight, they're much more likely to sustain a strain. And in the kids who are growing, that bone can lengthen rapidly, and the muscle tendon unit may have trouble keeping up that rate of growth and will become a lot tighter when they're going through a growth spurt. In general, poor mechanics or technique is always going to contribute to overuse injuries in your throwing athletes. Inadequate rest is a big one. A lot of these children are participating on more than one baseball team at a time. They might not be following their pitch counts from one team to another, and now they're exceeding what the pitch count recommendations are for their age. Throwing fatigued also plays into inadequate rest, and that's probably one of your faster ways to get into the overuse injury and pain, because your mechanics start breaking down. You start using accessory muscles when you're fatigued, and you're really setting yourself up at that point to injure your elbow or your shoulder. Early sports specialization, which is essentially, I'll get into more later, but focusing on one sport year-round, and that has been shown through a multitude of literature to contribute to overuse injuries, not just in baseball, but in many other sports as well. So let's kind of break down what they are actually doing when they are pitching the baseball. So the pitch itself starts with the wind-up, and that kind of sets the timing, sets the routine. So when a pitcher is pitching, let's say their fastball, the way to have the most consistent and accurate pitch is to do the motion the exact same way every single time. And that's what gives the pitchers more of a control and command of the baseball. So the wind-up is sort of settling into that routine and preparing for that coordinated series of events that lead to ball release. Really no injury mechanism during that wind-up phase. Then you get into early cocking. Early cocking is also called the stride phase, and that phase goes from that max leg height, which is the end of your wind-up, to that front leg hitting down on the ground. And that stride phase is what's happening during that phase is the pelvis is starting to rotate a little bit towards the batter through rotation of the trunk. So the pitcher's trying to avoid rotating their torso towards the mound. So they are building up elastic energy through the spine as the pelvis starts to rotate forward. And this is called hip-shoulder separation. And the more they can maintain that hip-shoulder separation, the faster they will be able to throw the baseball. Also, the more they maintain it, the less likely they are to have an elbow injury. And that's one of the biggest mistakes of your youth pitchers is they open up early, meaning they start to rotate their torso along with their pelvis towards the batter. Then you get to late cocking. And late cocking is from the time that front foot steps down to maximum external rotation of the shoulder. So that's what you're seeing over that image where it shows late cocking. That shoulder is maximally externally rotated. It almost looks like from the front that their arm is almost on backwards. And that's preparing for that final acceleration. So what they are doing is storing up all this elastic energy in the muscles in preparation for propelling all of that forwards. And in that late cocking stage, that's where you start seeing issues with shoulder instability, with internal impingement of the shoulder, slat tears, your apophysitis of the elbow, your UCL injuries. Most of that is towards the end of early cocking into the late cocking and then the start of acceleration. So then at acceleration, that goes from that maximal external rotation of the shoulder until release of the baseball. And that in your professional players can occur at a rate of 9,000 degrees of angular velocity per second, literally the fastest human motion known in existence. After that ball is released, now you've got that tremendous velocity and you got to put on the brakes. And that's the deceleration phase. And that goes from that ball release until maximum internal rotation of the shoulder. And this is also a big injury driver. So you're getting extreme eccentric contraction of the musculature in the posterior shoulder, posterior rotator cuff, posterior aspect of the deltoid. This is the driver of some of your slat tears as well, significant muscular strains, bicep tendon injuries. And then the final phase is your follow-through. And then similar to wind-up follow-through is sort of a resetting of yourself, and it puts the pitcher into their ready position so that they're basically ready to field the ball should it come back their way. So why this sequence of events? Why is this what the pitchers are doing exactly? So this is basically what's called a kinetic chain. You're transferring energy. So there's a coordinated sequence of body movements and muscular forces that transfer that energy extremely efficiently from the lower extremities and torso out to the arm to impart maximum velocity of the baseball while also maintaining the accuracy of the pitch as well. And so that series of events contributes to the majority of injuries that we see in the youth and adolescent baseball player. So moving on now specifically to the injuries themselves, I'll touch upon treatment at the end because the treatment for a lot of these things is very, very similar in nature. So the thing that I typically see most commonly is just your run-of-the-mill muscle strains, tendon strains, tendinitis. And this occurs when the muscle is stretched beyond its elastic limit or forcefully contracted too strongly, thereby also exceeding its elastic limit. And in the throwing athlete, important to remember that not all of these muscular strains are going to be in the upper extremity. Let's say they stride too far down the mound. They can pull a hamstring doing that. And any injury to the lower leg is going to also affect their throw and just take them off the mound. Even a minor muscular strain in the legs should stop them from throwing to avoid injury in the shoulder or the elbow. So what you're going to see in the muscular strains is generally not always bruising like this picture. That's a pretty severe sort of grade 3 muscular strain, that means a tear, but often they're going to have complaint of pain over the muscle belly, so it's sort of midway through the leg or midpoint over the humerus, and they may or may not have tenderness to palpation there. They usually don't have any obvious swelling, but most consistently they'll have pain with stretch of the muscle. So if you're looking at the quad, for example, you can test this by having them lie prone and flexing at their knee, bringing their heel up to their bottom. So you're not moving the hip at all. So if it's a hip issue of hip pathology, you're not going to reproduce pain doing that. But if it's a muscular strain, by stretching the quad, you're going to pick up pain due to injury to the quad muscle. Stretching the hamstrings on exam, same idea. Also, you're going to have pain reproduced by engaging that muscle. So if we're talking about, again, the quad, you're talking about extending the knee against resistance. If you're talking about the biceps, you're having them sort of flex at their elbows against resistance. You'll also see some weakness on exam, but that's not specific to a muscle tendon strain. That could be with any pathology. You'll see generalized weakness secondary to pain. But with the muscle strains, generally, when you have them engage that muscle, that's when you're going to be reproducing the pain. Tendon strains, same idea, except the pain is more localized closer to the joint over a tendon. And with tendinitis, it's more of a chronic overuse of that tendon, resulting in inflammation in that area. Now, most specific to your youth athletes, your little league players, your middle school players, are the injuries that affect the areas of growth. And they come in two broad categories that are essentially varieties of the same thing. Epiphysiolysis, which is widening, sort of stress fracture through a physis that contributes to length of the bone, and apophysitis, which is essentially the same thing, but through a physeal area does not contribute to overall length of the bone. So in epiphysiolysis, we're really talking about the proximal humeral physis, seen here in the image. You got a nice little radiologist arrow sign pointing to the widening of the physis on that leftmost image compared to the comparison on the other side, what the physis should normally look like at that age. So this is a type of injury that is going to present with tenderness right at the very proximal extent of the humerus. They probably won't have any visible swelling, although they might if it's a pretty advanced case. They're going to have some generalized diminished range of motion in all planes, and they would typically have pain during that deceleration phase of the pitching motion. In apophysitis, this is sort of your pediatric version of your ulnar collateral ligament sprain. In the proximal humerus, it's more like your pediatric equivalent of a rotator cuff injury. In the medial epicondyle, which you're looking at on your leftmost image, the one that is the dominant arm of the patient, and on the right side of the screen, your non-dominant arm. And you can see some pretty dramatic differences between those two images in this same patient. And what you're seeing there is significant hypertrophy of the medial epicondyle. You're seeing widening of the physis. You're also seeing almost equivalent to osteophyte formation, basically a traction spur at the most inferior aspect of the medial epicondyle where that ulnar collateral ligament attaches. So this x-ray actually was in a patient of mine that was only 11 years old. So 11 years old, they're pitching maybe around age 8. So in 3 years of pitching, 3 years, they have developed substantial bony changes. This is dramatic. This is a kid who I might caution to pick a different position that they enjoy almost as much as pitching, because they are already going down a road where they're going to end up with more and more chronic injuries and perhaps even take themselves out of baseball entirely. Not to say that they can't continue to pitch, but they will have to make dramatic changes in order to do so safely. So I tell the kids who come in with the epiphysiolysis or apophysitis that this is sort of their one-time get-out-of-jail-free card, or more clearly, they're to sort of get-out-of-surgery-free card, because these are the pediatric equivalents, like I said, of the future rotator cuff tear and the future ulnar collateral ligament tear that leads them down the road to Tommy John surgery. So what I mean by that is, at this point in time, the changes to the bone are not really permanent changes. The bone will heal, and it will heal well enough that this will not cause any deficit in function down the line, as long as they sort of change their ways. So this is sort of their warning sign that they really need to pursue significant changes in what they are doing in order to prevent more severe injury in the future. And the kids with apophysitis of that medial epicondyle, they're generally very point tender right over the medial epicondyle. If it's also very inflamed, they will have diminished flexion and extension of the elbow. Something else I often see in these kids is a diminished strength in the shoulder. So if you think back to that kinetic chain, if there's any weakness in the link in that chain, you're going to put increased stress at the next body unit down. So if you have some weakness in the shoulder, you're going to put increased stress across the medial elbow, because that's where you're getting those valgus forces across the elbow. And in these kids with the apophysitis, what I'm seeing, despite any lack of shoulder pain or shoulder injury, is I'm typically seeing a significantly diminished strength in external rotation of the shoulder and shoulder abduction. And that goes back to that gradual microtrauma over time. And despite it being their dominant arm, they're very surprised that they have an underlying weakness. And that is often what leads to the injury at the elbow. So moving on to sort of a less common elbow injury, but seen most commonly in both actually your gymnasts, because they weight bear on their arms, and your baseball players, and that's OCD lesions of the elbow. And in this case, unlike the medial epicondylitis or apophysitis, where the injury is on the tension side of the elbow, here it's on the compression side of the elbow. OCD lesions are not particularly common in the capitellum. They're actually one of your least common places. They're most common in the knee, that being medial condyle, followed by patella, followed by lateral condyle, tibial plateau, then the talus at the ankle, and then finally the capitellum. So why is it so much more common in the knee? Probably because most people aren't weight-bearing on their elbows, except for your gymnasts and the equivalent of weight-bearing in your baseball players or throwers overall. Generally, this will occur in your tween and early teen adolescent population. They will have increasing joint pain, typically laterally. They will often have a joint diffusion, although not in the earlier stages of it. And your OCD is essentially an area of necrotic bone from just repetitive impact, whether it be the knee or the elbow or anywhere else. It's generally a repetitive impact type of injury, resulting in a little vascular insult to a specific area in the bone. X-rays are typically diagnostic of it, and then an MRI is typically ordered to evaluate the stability of the lesion, how advanced the lesion is. This should not be confused with Tanner's disease, which is relatively rare, but it's interesting, and I bring it up mostly because it needs to be distinguished from your OCD lesions, because OCD lesions sometimes require surgery. Tanner's disease does not. And Tanner's disease is your Legg-Calvé-Perthes disease of your elbow. And it's essentially a vascular insult, also related to some repetitive trauma to the area, but it involves the entirety of the capitellar epiphysis. It will typically present prior to age 10, and also with lateral elbow pain, diminished range of motion, and the x-rays are typically diagnostic for it. Some of that loss of motion is occasionally permanent, in that they will sometimes permanently lose 10, 20 degrees of extension. Now, this won't cause functional problems for them, but the patients definitely need to know in advance that permanent motion loss is common with this, even though it won't typically create a functional issue. Just like waiting out Perthes, waiting for that hip to gradually reossify and mature, Tanner's disease is the same, and that's going to take about 1 to 2 years of time. So it's a somewhat, although rare, somewhat devastating injury, because it really just fully takes them out of baseball for a very long time. So moving on a little bit to the shoulder now. The main things in the shoulder that you're going to see in your adolescent athlete are impingement, instability, and labral tears. So a lot of this has to do with compensatory shoulder. Is trying to increase the elastic or the potential energy stored up in their arm as they throw. So similar to a slingshot, the farther back, the farther they can externally rotate that shoulder and get their arm back, the more elastic energy there is to sort of spring forward and add velocity to the baseball. So in that repetitive external rotation, they are gradually loosening the anterior shoulder capsule, and so they may develop this sort of nondescript, vague shoulder pain, often felt a little bit more anteriorly, but definitely hard to localize due to the laxity of the shoulder over time. Now, in response to that, they will often tighten up the posterior joint capsule as a compensatory measure as well. So they may feel almost like a pinching in the back of their shoulder, pain during that late cocking stage where it's in maximal external rotation, where the labrum is getting sort of pinched. And then if that continues, they can then start having posterior labral tears, and they will often also get a sort of peel back of the superior anterior labrum seen on MRI. Now, something very important to note in your baseball players is not to necessarily repair that anterior superior labral injury or tear, because what's happening there is the humeral head is sort of peeling it back over time in order for that shoulder to maximally externally rotate. So you repair that, and now you've potentially diminished the pitcher's shoulder motion and making it very hard for them to achieve the same velocity. So not every pathology warrants fixation. Some of them are just compensatory changes in the thrower's shoulder. And some of the symptoms they'll experience with any of these, with the instability, with the impingement, with labral tears, posterior pain, anterior pain, general soreness, popping, weakness. They might complain of a dead arm feeling and some diminished mobility. And now this one is sort of the bane of the existence of really any baseball player, whether it be a position player or most commonly your pitcher, and that's the ulnar collateral ligament sprain. This is the person who sort of ignored their get-out-of-jail-free card when they had the medial epicondylitis, or just didn't develop pain until they were approaching skeletal maturity or were already skeletally mature, where those valgus forces are now over the UCL rather than the apophysis, which was previously sort of your weakest link in the chain. And it typically affects the anterior band of your UCL, and the forces put across the elbow during the throw are tremendous. In your little league pitchers, it is typically topping out at about 20 Newton meters, and in your collegiate and professional players, over 100 Newton meters of force, valgus force, on the medial aspect of the elbow. And this injury typically will occur just prior to that point where they're reaching the maximal external rotation of the shoulder, leading into that acceleration phase of the throw. So what you'll see is tenderness, this time just distal to the medial epicondyle typically, or at the most inferior aspect of the medial epicondyle. Their velocity will gradually diminish. They'll get sort of thickening of the ligament. They'll get inflammation there, some diminished range of motion possibly. Their command of their pitches may diminish as well. Also running behind, just posterior to the medial epicondyle, is the ulnar nerve. And so that stretch across there, particularly as that ligament starts to lose its elasticity and you start kind of opening up on that medial aspect of the elbow, you're putting now tension on the ulnar nerve, and they may report some numbness in their ulnar 2 digits. Additionally, they may experience acute pop in the elbow, as can your kids with the apophysitis, the medial epicondylitis. They can actually go from just having a chronic inflammation to completely displacing that medial epicondyle. It's rare, but it can definitely happen. More commonly, though, you're seeing that in your ulnar collateral ligament injuries, where they've been pitching through pain, and then it finally goes. It just pops, and they lose all control of their arm at the time of the injury. And for this, the MRI is going to be diagnostic. So the typical patient that I see coming in with complaining of symptoms or pain are the kids generally who've been throwing through pain for months. And they come in, I diagnose them, and I say, okay, we've got to shut you down from pitching. And I see their eyes get wide, and they look at mom or dad, who's ever there, look back at me, look back at mom, and of course, they've got their championship game coming up in 3 or 4 days, and they were hoping that I would be able to fix them for this game, just wave my magic wand and make it all better. Unfortunately, as I'm sure this particular audience is aware, just doesn't work like that. So what do we do? The primary means of treating any overuse injury is rest. None of these kids want to hear it. They want instant gratification, back to sports. But the body has an incredible ability to self-repair at this age, particularly your tweens and your little leaguers, if we just allow it to do so. Other things that can help in addition to rest is for your apophysitis or epiphysiolysis, I do like using a course of NSAIDs briefly for a few days to help diminish the inflammation, which will help get their range of motion back more quickly and allow them to be more active participants in physical therapy more quickly as well. Stretching for any type of muscular strain, foam rolling the muscles has been shown to help speed up muscle recovery. I am a big proponent of physical therapy. So almost any thrower I have that's coming in with pain, there are some exceptions of course, I will send them right to physical therapy, not only for the purposes of helping them re-strengthen from the diminished strength that they've lost from the injury itself, but also so that they kind of start learning now that strengthening is a part of being a competitive athlete and that it will help prevent some of these injuries in the future. Once they are better, I like having them work with a pitching coach to check their mechanics, check their form, make sure that they're throwing properly to diminish future injury. When they're pain-free, it's not like they immediately get a pass back onto the pitcher's mound. When they're pain-free, that's when I let them bat, that's when I let them start throwing, gradually increasing their velocity, and playing as a position player in the field. For pitching, they really not only need to be pain-free, but to really have full strength in that arm. So that shoulder weakness that I was talking about in the pitchers, whether it be from a shoulder injury or an elbow injury, that really has to be at full strength before I will allow them to get back on the mound, because if it's not, they're going to be back in my office again with a repeat injury within a few months' time. Also, the flexibility should be back as well. So in some of these pathologies, conservative treatment is not going to be sufficient. So with your medial epicondyle, if that does acutely avulse, that's going to need at minimum a cast, but in more often than not, open reduction internal fixation. Generally in your non-throwing athletes, they say if it's displaced 1 centimeter or more from the fracture bed, that would be indication for ORIF. 5 millimeters to 10 millimeters is sort of a gray area, but in your gymnasts, in your baseball players, I will absolutely fix those because it is going to impact their ability to do sports. In a soccer player, sure, that would be absolutely fine to leave a 5 millimeter displaced medial epicondyle, but in baseball players, gymnasts, you really want that fixed anatomically or very close to anatomically if it's not sort of seated in an anatomic position on its own. OCD lesions, usually the primary means of treatment for that are rest as well and just waiting for that bone to reestablish blood flow. But if that doesn't happen over the course of 6 to 12 weeks, then you might need to go in surgically. Usually that would involve microfracturing, which means kind of taking a small wire and drilling from the avascular bone to the vascular bone, thereby reestablishing blood flow and allowing that OCD lesion to now have the nutrition to heal on its own. If it's more advanced, where it's unstable, then you might even need an open procedure to debride it and to fixate the bone that has started detaching from the underlying bed. For your UCL tears, that's going to often involve a ligament reconstruction. And this is occurring in athletes gradually younger and younger ages are undergoing UCL surgery. And it's an epidemic in this country right now because it's all about year-round sports, and so-and-so is pitching year-round. If I don't pitch year-round, then I'm not going to be as good of a pitcher as this person. So they are just continually pushing themselves and having these more adult pattern injuries earlier and earlier in their teenage years. For some UCL injuries that are more chronic in nature and not a severe. There may be a role for PRP, platelet-rich plasma injection. I know that's much more common in the adult population. It really hasn't been studied yet in your more teenage population. And then with labral tears, again, it depends on where the labral tear is and how severe it is. You don't want to repair something that is a compensatory fraying or peel back of the labrum, but for those posterior labral tears, if they don't improve with physical therapy, which is really focused on stretching that posterior joint capsule so that that impingement resolves, if that doesn't resolve their pain, then you might need to go in surgically and repair those. But even better than treatment is prevention. So to prevent these injuries there are different things that they should do, and the kids, hopefully, I try to educate them on this when they come in to see me, but oftentimes at that point it's a little bit too late. So I cannot emphasize enough stretching before and after activity, gradually ramping up activity level. So with COVID and the sports being canceled for an extended period of time, I had an onslaught of overuse injuries in all sports, just returning to their prior level of play because they ramped up from a long period of time of inactivity. Strengthening. So the strengthening piece, I like to start at a very young age, and it doesn't have to be weightlifting. Oftentimes with baseball players, it's resistance work, band work. So what they should be doing during the course of the season, as young as 7, 8 years old, if they really have an interest in pursuing pitching, is start working with resistance bands to sort of maintain strength during the course of the season. In the off season, that's when they should really work more extensively with resistance bands in trying to further improve strength around the shoulder, the arm, the hip abductors, the core. All of that plays into pitching. Time off, I cannot emphasize that enough either. So a pitcher should, or any baseball player, should take at least 2, if not 3, months off per year from throwing a baseball. The body just needs that time to recuperate through that microtrauma from the course of the season, even if they did not have any pain. This will serve them so much better than working with a pitching coach, which is not truly time off. They're still pitching weekly, still having that microtrauma weekly. Time off is no throwing baseball for 2 to 3 months at minimum each year. If you look at their velocities at the beginning of the season and at the end of the season, they slow down a few miles per hour. And that's because of that microtrauma that just builds up during the course of the season, even if it's not to the point where they're having pain. However, if they are having pain, rest it. Rest it. It is so difficult to get these kids to stop. So when they come in with pain, I ask, well, how much have you rested it? Usually it's none, or I've rested it for 2 days when they've had 3 months of pain. I asked my patients outright, I mean, somewhat kiddingly, but in all seriousness, so how much are they paying you on this team to pitch? How much are they paying you? And they look at me thinking, is this a trick question? And they'll look back at their parents and see what their response is. And usually mom or dad said, no, we're actually paying them. Of course they're paying them because they're, it's a team, there are expenses. But no, of course these kids aren't getting paid to pitch. So why are they throwing through pain? I'm trying to sort of instill in them the idea that their arm is a commodity, that they are their own best advocate, and their goal should be to protect it if they want to play in the long term. And that's not just for arms, it's for legs, it's for any time they are having pain or playing through pain for their sport. They are not contractually obligated to pitch through pain, so they shouldn't be doing it. Their coach should evaluate their form regularly and make sure that they aren't doing something obviously wrong that is going to result in an injury. During their baseball season, optimally, they should only be playing for one team. These days, it's almost always the rec team, and if they're really into baseball, it's the travel team. It's being less and less possible to keep them on just one team per season. But most importantly, if they are playing for 2 teams, they have to adhere to those pitch counts for both teams combined. Avoiding early sports specialization, no throwing when fatigued. When they start tiring, they're going to lose velocity, they're going to lose control anyway. It's best if they call the coach over. I remind them, as a pitcher, you are in control of this game. There's no other youth sport where you have control of a game as you do as a baseball pitcher. Take advantage of it. Be a diva. Call the coach over and say, you know what, I'm out. My elbow's hurting today. Got to call it quits. Got to protect the arm and come off the mound. And I just added rest if having pain because it just warrants a second or third mention. It's so important. And the earlier they rest, the sooner the rest, if they're having pain, the less rest they will need. So if they pitch through pain for months, they're going to need a very long time off to recover. If they're pitching through pain for a couple of days, then it could be a very short break from the sport before they're back in. So early sports specialization is something I've mentioned a couple of times, and it is defined by engaging in a single sport for at least 3 seasons per year at the exclusion of other sports before age 12. And this really goes for most sports. There are exceptions. For example, gymnasts, ice skaters, they have their peaks in mid-adolescence. And so if they don't specialize early, they will never be able to have the opportunity to peak in their sport if that's their goal. But what you find in gymnasts in particular that you're not seeing in baseball players is the stretching and the strengthening. Your gymnasts are out there in the gym, 9 hours a week. A good half an hour of that, if not more, is focused on both stretching and strengthening. And that's why in gymnasts, you're not seeing the same type of overuse injuries to the same extent. Obviously, the injury pattern is going to be different, but you're not going to see the rate of overuse injuries as you are in your baseball players, where it's often coached by parents who don't necessarily have the knowledge in your sort of sports conditioning, and they feel the kids are young and they don't need to stretch, they don't need to strengthen. Some kids, yes, a lot of kids, no. So early sports specialization is associated with a higher injury rate, more likely to also have an injury that requires surgery. And in a study done by Wilhelm et al., they found that early baseball specialization in particular did not improve your chances of becoming pro, but did increase your injury rate during your career. So the skills that you obtain in other sports really help you, make you a better athlete. So the movement that you do in basketball, that side-to-side movement that creates a lot of core strength, or in soccer, will make you a better baseball player, and vice versa. So doing other sports will not only help with your ability in all sports, but will also at the same time reduce your rate of overuse injuries. And these are my 2 throwing athletes, my daughter, the baseball player, and my son, not technically throwing, but the one who broke my heart and switched over to tennis. So thank you for your attention. And I'm not seeing any questions in the Q&A as of yet.
Yes, and as a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type your question in the small box at the bottom. Then when you're finished, hit the send button. Please note that due to our time constraints, our speaker may not be able to respond to all of your questions, but we are open for some now.
I think I might have answered everything. Oh, never mind, I got a question here. All right. In a perfect world, is there an age you would urge parents to wait until for sports specialization? I would say at a minimum until high school. But with that being said, if you look at a lot of your professional baseball players, professional football players, a lot of them considered going pro in other sports as well. So they were really high-level athletes in every sport and really didn't specialize until college. But if I had an age that I would urge them to wait until, I'd say at minimum 14, 15, your high school years. All right, I think that might be might be it for the questions. Right.
All right. Well, if there are no more questions, on behalf of Atlantic Health System Morristown Pediatric Orthopedics, I would like to thank you for your participation in tonight's event. You will now be redirected to the post-event survey requesting your feedback. Please do take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you and have a good day.